You still do it at the end, even like post-embolization or stenting.
Yeah, and this is the logic behind it. It's partly based on the fact that I think it's important to certainly hear at the early stages of us trying to establish the value of embolization, or maybe even critical time, trying to establish the value of embolization for women with chronic pelvic pain. We should be as complete in our embolization as possible. And there's definitely literature out there. We really only have limited high quality evidence. Most of the evidence that exists are case series. But if you look at the case series that do more thorough venography and more thorough embolization, you see greater improvements in visual analog scale pain severity, and you see better durability reported in terms of recurrent pain after the embolization. And so I think there is signal here that suggests a more thorough embolization is possible. So I'm a big believer in trying to sclerose the varicosities in the venous plexuses that are dilated and tortuous, probably hypertensive, much like the same way with getting rid of varicosities in the leg. I think the patients just feel better if you get rid of their varicosities in the leg in addition to ablating the saphenous vein that may be causing them. And I think in order to get a complete embolization, you need to get at it from all the possible ways that the reservoir can fill. And it can fill from the right ovarian, it can fill from both internal iliac veins. And the other thing to keep in mind is that the flow patterns change just like when we do embolizations of vascular malformations as you're doing the embolization. And you can consider the pelvic venous reservoir to be a low pressure venous malformation, if you will. And if you include the main reflexing pathway, the one that was the most hemodynamically impactful, that filled the reservoir immediately, let's say it's the left ovarian vein, you may find either on table or potentially a month or 3 months later that the right ovarian vein is now filling that reservoir if you left the reservoir there, or the internal iliac veins may be filling those reservoirs now. And so I think looking for all the sources and closing them off at this stage of our development of this procedure, both in terms of taking care of individual patients and trying to establish its validity in populations of patients anecdotally, and then in clinical and in scientific work is important. We can always back off later after evidence shows that embolization is important by doing subsequent studies to see if maybe less embolization is just as good. But I think now we should do everything we can so that we don't leave patients needing to come back for subsequent procedures all the time because we said, well, we didn't do everything, because that's just not going to give the procedure a good name. And certainly in clinical studies, we're not going to show effect. And if we don't show effect, we're probably not going to get too many more cracks at trying to do that in the future.
Sure.